Good morning, and welcome to Global Neurosciences Institute Grand Rounds. And now it is my great pleasure to introduce today's speaker, Dr. Gonzalo Revuelta. Dr. Revuelta is an associate professor of neurology and medical director of the Brain Stimulation program at Medical University of South Carolina. He earned his medical degree from the University of Medicine and Dentistry of New Jersey School of Osteopathic Medicine. He completed his residency in neurology at Drexel University College of Medicine, and after residency, he completed fellowship training in movement disorders and deep brain stimulation at Emory University School of Medicine. He's a member of the International Parkinson's Disease and Movement Disorder Society, the American Neurological Association, the Parkinson Study Group, the Huntington Study Group, and the Dystonia Coalition. He's also an elected fellow of the American Neurological Association. Dr. Revuelta's NIH-funded research program focuses on the understanding of the pathophysiology of freezing of gait in Parkinson's disease and also on an essential tremor, and the development of clinical trials for these conditions using neuromodulation therapies. He's involved in the treatment of patients with all types of movement disorders. And Dr. Revuelta will be speaking today about deep brain stimulation in Parkinson's disease. Dr. Revuelta.
Great. Well, pleasure to speak sort of virtually back in my old stomping grounds in Philly, where Peter and I were co-residents together. So we're old friends. So I want to talk a little bit about deep brain stimulation and Parkinson's disease. My research is in freezing of gait, like Peter mentioned, but it's been using different forms of neuromodulation. So it's exciting to get the lab working a little bit more in the deep brain stimulation, which is really what I do clinically most of the time. So I just wanted to quickly go over my disclosures since this is a CME activity. So I did participate in one of the studies that I'm going to talk about today, the Intrepid trial. So I was one of the site PI for that. And I did a little bit consulting for Boston and for Neil, and I have grants from a lot of the device companies, and these are my research and disclosures. So let's see if I can minimize this. So the objectives of the talk, I wanted to talk a little bit about kind of the evidence that we have today for the use of DBS in Parkinson's disease and kind of where we are with the technology, then what the unmet needs are. I'll be kind of stressing those throughout. And some major areas of ongoing research and a little bit of what we're doing in our research at the very end. Oh, okay. So this is the big trials that that were done for deep brain stimulation to really show efficacy for deep brain stimulation. They're kind of old. If you look at them, this is 2006, 2009, 2010. So these are trials. This is how we design trials for DBS. Initially, we had patients that were good candidates for deep brain stimulation, and we compared them to best medical therapy. So the primary outcomes for this type of trials, these are patients that have lots of these motor fluctuations. These are not really patients that have tremor predominant Parkinson's disease. Those patients actually do better with DBS. So this is even a little bit less of the type of effect that we would see when it comes to reductions in Parkinson's severity if you really included the tremor patients. So the primary outcomes is on time, right? Patients take the medicine, they feel good, they feel great, really, almost normal, and then it wears off. And then we have to increase the medicine, and then the patients develop dyskinesias. So good on time is on time without troublesome dyskinesias, and that's what the primary outcome was for these trials. They showed improvement of about 4.5 hours of on time without troublesome dyskinesia, but they also showed improvement in everything else. So really things like quality of life. If you look here from one of the studies, all the kind of DBS studies have a table like this where you see the darker bar is DBS and the lighter bar is best medical therapy or medication. And the patients with DBS, if you look here, the PDQ-39, this is a quality of life questionnaire, mobility, activities of daily living, even things like emotional well-being, stigma, bodily discomfort, social support, cognition, all these things were way better with deep brain stimulation than with medication. So not just the scales that we look at. So the next study that came out that I remember was an important kind of clinical evidence of the efficacy of DBS was the early STEM study. It came out of Germany in 2013. So this is a study that looked at patients that were a little milder. So if you look at disease duration, they had Parkinson's for about 7 years. They had the duration of having dyskinesias was just about 1.5 years, and the duration of motor fluctuations, or this off time, was about 1.5 years. So kind of mild, but they showed the same type of efficacy, the same type of improvement in things like quality of life, which is what you see up here with medication being at the top, and a reduction, significantly greater reduction in quality of life, or improvement in quality of life with neurostimulation or DBS. And then again, across all the other categories that we talked about, there was significant improvement. So you could do DBS earlier. This now is when we do DBS. We don't really wait for 10, 15, 20 years, last resort to do DBS. But it was nice to see this. And then the next trial that I wanted to talk about was the one that we did participate in, called the Intrepid trial. So this was this paper just came out a couple of years ago. So this is, I think, 2020, 2021. And this is the first sham-controlled study for deep brain stimulation. It's also much closer to how we do things now. So you think in a decade, we've got a lot better at doing this. And so I wanted to see kind of where we were with our efficacy and also with side effects. So you think, how are you going to do sham DBS? You don't do sham surgery on patients. That's not really ethical. So this is pretty straightforward. If you look here, this is when patients were randomized to either having, so everybody got the surgery, everybody got the lead implanted, and they were randomized to either real stimulation, where you optimize the stimulation to efficacy, or sham stimulation, where it's definitely subtherapeutic stimulation. And the patient is blinded, the rater is blinded, the patient, the person that's actually programmed the device is the only participant that is not blinded. So it was a pretty good design. It was the first time that we see this kind of evidence. This is a busy table, but I'll highlight a couple of important. So this is like all the results. We're looking at active and controlled, and we saw an improvement of about, from 7.8 to 12.4 of on time without troubles on dyskinesia. So that's the number one, the primary endpoint of the study. And then if we look at the control group, there was only a slight improvement. So there was definitely a significant improvement of about 3 hours comparing the active and the sham group. So that was great. But again, we also saw improvement in all those other things. So it's not just the primary endpoint. It really is PD severity, quality of life, and all that stuff. So the other neat part about the study is that it had long-term follow-up. So now we could see 1-year outcomes. And as you can see here, the UPDRS, which is just the severity of the Parkinson's disease, that's the severity scale that we use, showed improvement, from screening to 26 weeks. That was sustained to 52 weeks. And then again, the same with on time, and the same with like the total UPDRS, which takes into account everything. So not just motor severity, but some non-motor symptoms and activities of daily living. So that was great. This study actually was carried out to 5 years. We just finished the 5th year. We just kind of still haven't actually closed out the study completely. So we should see some 5-year data coming out. These are the adverse events, right? So this is something in the clinical world that we really think about, and we talk about to our patients when they're making a decision if this is something that they want to pursue. This here, I'll highlight, the percentages of the most important adverse events that we're really looking at. So we have infection, right? I always tell my patients, we're putting something foreign into your body. There's always going to be an inherent risk of infection. It's never zero. I was a little surprised that it was 4%. It's been lower in actually the other trials that I highlighted here. The risk of symptomatic intracranial hemorrhage, right? This is a big deal. This is my biggest fear. We can't get this down to 0. It's actually a little higher than has been reported in previous trials, but it's still very low at 2%. lead edema, yeah, and even intracranial hemorrhage and even infections, it really depends on what you're counting, right? So sometimes it's just a little bit of redness over the generator site. That's not usually something I even remember about clinically. If that was an issue, I may not even hear about it if someone just gets an oral antibiotic. Same thing with some intracranial hemorrhages or edema. It's not uncommon if you do a CAT scan right after or a few weeks after that you still see a little bit of edema. And it's rarely symptomatic, but if a patient's like a little bit stunned after surgery, will you call that symptomatic? So I think this is where you see the numbers differ between studies. It depends on what you count. Hardware malfunction, which was around 2% there, and like erosion of the hardware around 1%. I was a little surprised. I think in my whole career, I've seen maybe one patient that had a hardware malfunction. But this is a new device, right? So that might have been related to the fact that the surgeons weren't quite used to this new device, and some of the hardware may not have been fully flushed out. So this is on the right, and looking at what do you allocate the serious adverse event to? Was it hardware? Was it stimulation? Or was it the procedure itself? So you can see that maybe a little bit more procedure. I'd say for those that are not very familiar with DBS, the deep brain stimulation is adjustable and reversible. So if we do have a side effect that's related to the stimulation, we can shift away from that. And I'll talk a little bit more about that in a few slides. So to summarize the findings in this particular study, we had, so this is now, sham controlled evidence. So this is class 1 evidence of efficacy. It's the first time we have class 1 evidence of efficacy with deep brain stimulation for Parkinson's disease. It also improved Parkinson's severity, quality of life, and on time remains significantly improved at a year. So it's the first time we have evidence that far out. If you look at not comparing controls, the improvement in on time was 5.5 hours, 5.6, and with a 42% reduction in Parkinson's severity. So that's actually the biggest that we've seen in any of the trials, which makes sense because we do have a decade of experience with this. And then, in general, this is still surgery, and there's still up to 13% if you combine all of the things that I looked at on that table of having some serious adverse events. So it's still something to think about. And that's why we think about it so much when we're considering this for our patients. So I wanted to talk a little bit about the technology, right? Because this is, technology is important when we're talking about deep brain stimulation. So if you look at these leads over here on their A, I don't know if you guys can see my pointer. These are the traditional leads. So this is the Medtronic, we call it the 3389 lead that has the close spacing of these contacts that we stimulate through. This is the Medtronic 3387 that has a little bit more wider apart contacts. And this is actually the lead that was used in the Intrepid study. This is a Boston Scientific, called the Inline 8 lead, which is still available. But we don't really use these too much anymore. I'll say this one that was used in the study, one of the technological advances of it was that it had an independent current source for each one of these contacts. So that was the first time that we saw that in deep brain stimulation anyway. So you can more precisely allocate current to each one of these contacts. And that's the one that we use in the Intrepid study. So these over here in the B are the segmented leads. So if you look closely, there is a little slit in these contacts and between these two middle kind of contacts. This is the Boston Scientific one, and this is what the Abbott and Medtronic leads look like now. No one's ever made a lead like this with the little holes. The concept of segmented the leads is pretty neat. I think kind of a game changer. So if you look up here, this is how we've done DBS forever. You have a lead in the middle. This is like a cross section of that. And you have a sweet spot in green and a sour spot in red. So if you stimulate, you generate this, basically it's like a spherical shape of the tissue that you're activating around the active contact. And you're gonna both reach the sweet spot and the sour spot. And so you're going to have efficacy, but you're also going to have a side effect. So in the idea with segmented leads is that you can now steer away from the sour spot. So if you see over here, you're completely into the sweet spot, creating, generating efficacy and avoiding any side effects. So that's simple enough, hard to pull off, but quite effective in our patients. So this is another representation of this. This is what the models that we use, and we actually use these clinically as well as in research, but they are available clinically with both Medtronic and Boston lead setups for programming. They can be quite accurate, although still being validated. And then the idea is that if you place this lead, and again, you take a cross section of the lead in the subthalamic nucleus target, and this is, the capsule is lateral to it. So this is the internal capsule. If you activate this lead like this with a volume of tissue activated like that, a spherical volume, you're going to have efficacy because you're kind of in the lateral and posterior part of the subthalamic nucleus, which is where you need to be, but you're also going to spread into the capsule, and it typically causes issues with speech dysarthria. And so if you have a segmented lead, you can just steer away from that. So it's a very effective way of avoiding side effects and getting into the more effective zone of your target. So the other big technological advancement that a lot of folks are talking about, and it looks like we're getting closer to every day, is that we can actually, there's two really big labs and maybe three that have been really working on understanding what's happening in the brain from a neurophysiology perspective. And they have figured out that there are these beta oscillations that you can record from the target, from your subthalamic nucleus person, that's the most common target. And you can detect these oscillations in the beta oscillations, and they correlate with Parkinson's motor symptoms like bradykinesia. So when you've seen these patients that are implanted, and you can see the recording of the beta oscillation, and you can see the bradykinesia, and then you stimulate and you obliterate the beta oscillation, you see improvement in those clinical symptoms. So they've been able to show this over and over again, and they think, well, why don't we generate or create a device that can record those beta oscillations, capture them, and then stimulate accordingly based on those oscillations. So you would only stimulate intermittently, and then if the beta oscillation comes back, then you stimulate again. And so that's what the concept of closed loop or adaptive DBS is. So we're able to do some of this right now clinically in the devices. So you can sense, is what Medtronic calls it. This is the only device that can do this as a Medtronic device. So they're the ones that came up with this more adaptive stimulation terminology. So what you can do, this is their lead, and you can say, okay, what are the beta oscillations? What does that beta peak look like between these two areas? And what about between those two areas? So you can see the different combinations that you can look at here, and you can say, where is that beta peak highest? And that allows you to maybe pick which is the best of those four segments that you can stimulate through. So that's the idea right now, what this technology can do. So to summarize the current state of evidence of DBS for Parkinson's disease, we have, like I mentioned, class 1 evidence for efficacy, which is pretty cool. We know we can improve on time and without troublesome dyskinesias up to 5.5 hours, 3 hours compared to sham. 42% efficacy on the motor symptoms or motor severity of Parkinson's. We can improve quality of life compared to best medical therapy, and that remains improved at least at the 1-year mark. Clinically, we see the improvement remains indefinitely, even though the disease progresses. So we'll see what that 5-year data shows. And then that we can really improve our therapeutic window a lot when we use segmented stimulation. That's been shown. And then now we have this ability to detect the beta peak, although it's still, typically in centers that do this a lot, we are able to pick where to stimulate quite easily. It's just, so it's undetermined, I think, clinical significance, what our current ability to detect the beta peak can really do. So I think we get into what are the challenges, what are the unmet needs of DBS currently. So it doesn't treat a lot of aspects of gait. I'm going to get into this more. It doesn't treat cognition, and it doesn't treat speech. So speech can worsen with DBS, like I mentioned, if you spread the current into the internal capsule. But we have no way of treating it. And these three issues are the most debilitating problems that we have with Parkinson's disease, right? So if you can't walk and can't talk and can't think, then that's a much bigger deal than if your hand shakes or there's slowness or stiffness. So I think these are our big challenges moving forward with DBS. I'm going to just show a video. This is a patient of mine.
Like that?
So I asked her to walk, right? So she is having a tough time just getting started walking. You can see she's trying, but there's a lot of hesitation with her stepping. But as soon as she gets through that, she does pretty well. And this is off of her medication. So this is a DBS evaluation. Well, we try to see if patients at their worst, and we try to say, okay, what can DBS do for you? And then we decide really together with the patient if DBS is a good thing for her. But you can see that even off meds, she can really get going. See her turn here, and she hesitates a little and kind of gets going again. And then she looks okay. She's a tough lady. You can see another big freeze there that she kind of breaks through. This is a good example of freezing of gait. It's very unpredictable. So the patient doesn't know when she's going to have a really big freezing event like this. Since wearing off can be unpredictable, patients are very bothered by this. They become hesitant to go outside. Things like turns or changes in patterns on the floor are a big problem. An elevator door opening. If I go to that restaurant, will I be able to walk out? So then maybe I just don't go to the restaurant. It's actually one of the highest, so the second highest cause of poor quality of life and nursing home placement, leading to falls in particular for patients with Parkinson's disease. And I don't know if it's going to help. I can't really tell her if DBS is going to help her freezing of gait or not. She has wearing off and she has dyskinesia, so I know I can improve her on time without troublesome dyskinesia. There's class 1 evidence of that, but I don't know about her freezing. So I wanted to highlight this study that looked exactly at this, at whether or not DBS can improve freezing of gait. So traditionally, it's not thought to be, freezing of gait was not thought to be responsive. We've come to know that some people respond, but we just don't know who. In theory, the subthalamic nucleus, which is the main target, is a locomotor center. So you would think it has a lot to do with gait, and we can really modulate gait in this way. But we just don't know. So it's, let me show you a little bit more about the study. This study, one of the reasons I talked to you guys about the early STIM study is because this is kind of a follow-up or secondary analysis of the early STIM study. So these are those folks that had fairly early disease, and then they looked at how many of those had freezing of gait, and did the freezing of gait improve. So they assessed freezing of gait just looking at the item 14 question of the freezing of the UPDRS, which says, do you have freezing? And it's just like a 1 through 4 questionnaire of asking the patient about their freezing. And then they looked at the PIGD score in the UPDRS. So these are exam parts of the more objective part of the UPDRS that look at factors that have to do with gait or walking or standing or posture. And then they also watched them walk, and they counted the number of steps in a 7-meter walk with a turn, and then how long it took them to do that, and if they froze, a number of freezing episodes. So it was really interesting. If you look over here at the bar graph, DBS in blue and best medical therapy in the kind of candy stripe pattern. So this is a baseline. So if you look at percentage of patients with freezing of gait, 50% of patients at baseline in an early cohort of Parkinson's had freezing of gait. So it's a big number for patients that are supposed to be earlier. And then if you look at 5 months after DBS, 50% of those, so it looks like half the patients that used to have freezing before DBS still have freezing after DBS. So there was like about a 50% response that seems to kind of creep up a little, up to 34% after 2 years. So if you look a little bit more at the data, this is those items of the examination portion of the UPDRS and you see a big drop off in patients with DBS pre to post, and actually a little bit of an increase in patients in best medical therapy. If you look at the individual items, we see, yeah, that's the drop off. If you look at the individual items, you see improvement in each one of those in DBS, and not so much, if anything, maybe a worsening in best medical therapy. The only area that you don't see an improvement is here, and that's because patients on DBS, on medications, right? They do well, right? On meds, they feel great. They feel almost normal. So it's going to be difficult to see an improvement between on medications. So, so there is a response, you know, and I do see that in my clinic. I just don't know which side of the coin each one of my patients is going to be. So, I mean, which side of the coin my patient's going to be. And so we saw that 60% of patients with freezing of gait improved with DBS, while only 28% with best medical therapy. So 50% of them didn't have it, like we mentioned, 6 months after surgery, and that kind of crept up to 34% at 2 years. It was interesting. We thought like maybe some patients could have DBS, freezing of gait from DBS, and that did not happen. There was no reports of that. But 12% of patients actually developed freezing of gait in that time that they were being followed. So that happens sometimes too. I'll have a patient that we do DBS, and a year or two later, they start developing some freezing. I think maybe it's the DBS, but it's actually just disease progression. So, you know, I think it shows evidence that ST and DBS can definitely improve freezing of gait, and no evidence that it can worsen it, but we just don't know who. So then I wanted to get to the portion of Grand Rounds where I wanted to talk about the future of DBS. You know, so what I have, you know, kind of broke it up into the areas that are being proposed as advances in DBS and what we can expect from them. So we have better technology, right? We talked a little bit about technology. So we have this whole notion of adaptive DBS or closed loop DBS. And then I didn't really talk about this, but there's always been a talk about making their generators smaller. They have gotten a lot smaller, you know, through the years, and particularly the rechargeable generators. I didn't really talk too much about the use of tractography for targeting, but there's a good bit of research in that area. What I'll say about this is that I do a good bit of research in tractography myself. It is an indirect measure of where these fibers are. So you're basically looking at the probability that there might be a fiber going through that area. And then you have, when you look at the tractography, you see a depiction of where those areas could be, but it's not real. It's only a probability, based on where you put your seed and based on many mathematical assumptions that are way over my head. But it's difficult to plan or target based on something that's not really there, potentially. And then, I think there's ways of doing programming a lot easier because it's getting quite complicated. And maybe through sensing, it would ease our ability to program and make it a little simpler, pick that best area for each patient based on sensing those beta peaks. And then there's a lot of talk about a sleep DBS, right? Which is not really, I can put any of my patients to sleep. We do all neurophysiology guided, right? So we look at the neurophysiology in the operating room to guide where we place the DBS lead, and we test in awake patients. But I can put them asleep. The issue is, what do you use to guide? And so a sleep DBS, where patients are under general anesthesia, you only use MRI to guide the surgery. And that, I think, has an inherent limitation because some of the areas, like particularly the VIM nucleus in the thalamus, is not at all visible. Certainly in a 3T. And the subthalamic nucleus, you could see some contours, but you can't really see particularly the ventral border very well. So it's tough to do these, even if you have tractography, which, like I said, has its limitations. So what do we expect if these proposed future technological advancements will really all take effect? So I would think the generators are going to last a lot longer. They always get smaller. They last longer. If we do adaptive DBS, then you're only intermittently stimulating, so you use a lot less current. Our targeting approaches might get better. Hopefully, maybe the tractography gets a lot better. And the modeling gets a lot better, and you can really see where you're going. Maybe the imaging gets a lot better, and you can really see where you're going, so you can get to that spot quicker and more precisely. In the programming sessions, so my job will be easier if you walk in and you can already see exactly by making recordings and sensing exactly where you would go. If you can get down to the segment, not just the level. And then if patients can do this asleep, then it will be a more convenient surgical experience for each patient, which will be great. So the whole issue about closed loop and adaptive DBS is being studied in the ADAPT-PD clinical trial. So we're all looking to see the results of this study. It should be exciting. It's 100 patients. It's a prospective, single-blind, randomized crossover study of patients with receiving adaptive DBS with Parkinson's disease. It's over 10 sites in the U.S., Canada, or Europe. And the primary outcome is, like all the other studies, on time without troublesome dyskinesia. The secondary outcome is going to be stimulation energy use, because like I mentioned, if you only intermittently stimulate, you're going to use less energy. And then safety, right? Safety is always important. So I mentioned that the unmet needs are things like cognition, gait, and speech. Will adaptive DBS address these? So I find it curious that I don't see anything in the design of this study or any claims when I've heard the folks that are doing this research that it would improve side effects or address freezing of gait or address any other gait problem or cognition or some of these main issues that I think are important. So I think while it's conceivable that it could particularly have less side effects or maybe even treat something episodic like freezing of gait, I don't see people really going in that direction. There was one study that looked at deep brain stimulation, closed loop deep brain stimulation for freezing of gait. This is by an excellent group at the University of Florida. And it was a small study, only 5 subjects, and it was early, and I think we can do a lot better. But it was interesting that how much trouble they had with this study, as far as lots of problems with side effects, adverse events. So there's a lot of logistic. This is just to be fair. This is a study that was done with 4 leads, 2 in the GPI and 2 in the peduncle-pontine nucleus to treat freezing of gait, and with a closed loop setup. So there's a lot that was going on in this study, but I think still a lot of things that we need to kind of work out to get to the point where we can really see if closed loop or adaptive DBS is going to treat some of these conditions. There's a lot of good research in Tourette's, which is another episodic condition that closed loop may help with. So what are the barriers to this future of DBS, where we can really do everything we want with improvement in technology and convenience and reducing side effects and actually targeting these more resistance issues? So I think it's quite curious that we've been doing DBS for 35 years and we still don't know exactly what it does. There's a lot of structures that are being affected with, we talk about putting this DBS lead in a target, but there's a lot of brain that is being involved that we're really targeting. It's not just the one kind of anatomical target. We really do not understand why some patients respond and their walking gets a lot better and everything gets better, and some patients don't. Some patients can even get worse when it comes to cognition. So what are the factors that predict response? This is the traditional model that we have for DBS. And so I have here, my research is focused on fog or freezing of gait. But this is the traditional model of the basal ganglia, by Dr. DeLong and Alexander and Wickman and Young and all those folks that worked on this, decades ago. So, basically you have the substantia nigra in the middle of the diagram. You have your direct pathway this way, and your indirect pathway that stops in the GPE and the STN, and then down to the GPI, which feeds back to the thalamus and back to the cortical areas. So with Parkinson's disease, you lose the substantia nigra, you lose this kind of control or balance between the direct and indirect pathways and D1 and D2 receptors. And then you have this over or disinhibited subthalamic nucleus that really excites the GPI and exerts an inhibitory influence back on the thalamus. So what we thought is like, well, what does DBS do to this whole thing? So you put a probe in the GPI. That's the another target for DBS that we target, and we quite commonly at MUSC. And then when you do that, then you kind of normalize the output of the GPI back to the thalamus and the cortex. But you can also put a probe in the subthalamic nucleus, which normalizes the output of the subthalamic nucleus and the influence on the subthalamic nucleus to the GPI, and then back to the thalamus and the cortex. It's also interesting that the GPI feeds into the brainstem, which is really the pedunculopontine nucleus, which we think as being another major locomotor site. So there's lots of kind of gait that is closely related to this loop here. So that's what we think, normalizing activity, whatever that means. But there's a lot of talk about this. We've known for a long time that you could lesion these areas and cause really beneficial effects. So how come? So if we're lesioning and we cause the same effects as when we quote unquote stimulate, maybe we are just lesioning to begin with, but not always. Maybe it depends on how you do it. And then, what does that mean? What does even a lesion do? So I thought I'd briefly introduce this paper, which I thought was really interesting. It's really mostly theoretical, but they looked at patients that had DBS and had a cognitive decline from STN DBS. And they said, okay, well, let me look. So this is where the leads were in this group of patients. And let's look at what networks were actually activated, the entire brain that was activated based on stimulating in that one target site. And then let's reprogram the DBS so that we can, maybe improve cognition or activate a different network. So that's an interesting theory. This is another way of looking at it. This is from an editorial that was written on this paper. So if you have your DBS lead here on this, this white structure here, it looks like the subthalamic nucleus. Then you have this red kind of bubble here, which is the volume of tissue that is activated when you turn on the DBS and you program it correctly. And then, you talk about, well, what lights up? Well, what areas are connected, usually functionally, is what this paper did, and what a lot of people think about. What are the areas that are functionally connected to that bubble of volume of tissue that you're activating with stimulation? And then, if there's an overlap, then does that explain why, maybe you activated a cognitive network or you blocked a cognitive network, and that's why patients have these cognitive side effects. So a lot to be done, more work to be done to validate this kind of thinking, but it's neat to think about it, I think, in this way. So this is some of the work that we are doing, super preliminary. This is unpublished work. So this is a group of patients that had DBS and had freezing of gait prior to DBS. And in green up here, you can see the patients that responded, that had a response to STN DBS, and red is the ones that didn't. So this is all patients in the subthalamic nucleus, which is this kind of orange area here. We always target the part of the subthalamic nucleus that is posterior, so in the back of the nucleus, lateral, and dorsal. So these bubbles here, these are representation of the volume of tissue activated based on individual patient settings, DBS programming settings. And you can see the red are the responders and the green are the non-responders. So then we looked and said, okay, let's look at what those areas are connected to, and responders and non-responders. And we picked some areas that we thought were relevant to basically motor function and maybe to walking. And we said, let's look at these areas in general. So this is our preliminary findings, and we did seem to show that patients that had a response had greater structural connectivity, by looking at the number of streamlines to areas in so these cortical areas, well, cortical and subcortical, because we looked at the GPI, GPE, and the caudate and putamen as well. So food for thought. We're thinking about it more. I have been really impressed by this one patient. So this is a patient that had I'll present her case here, since I think we have time. So this is a patient that had a really bad tremor in her right hand, and I tried to help her with medications, and we weren't getting anywhere. So we did DBS on the left STN. So that's this DBS. So this is the individual patient placement, and to treat her tremor. So this looks posterior, but this is actually quite right. This is where we want to place the lead in the STN in these patients. And she had an excellent response to this. You can see it's kind of faint, but you can see here the volume of tissue activated based on the individual settings. She did not have freezing initially, but she developed freezing, and it was I thought, well, can I reprogram her? Can I, and I even if I turned the DBS off, her tremor will come back and she'd be uncomfortable, but her freezing wouldn't get any better. So we left the DBS on, treating her tremor. I, put her back on medication. She was very dyskinetic. And her freezing was sort of improving, but not really. And, fast forward a couple of years, she was really frustrated with her freezing. And I said, well, what if we do the right? But she didn't really have many symptoms on the left side. It would just be doing the right hemisphere, the right STN target, to see if her freezing would get better. And, she asked me, well, do you think it will? And I said, well, looks like you got a 50-50 chance based on the literature. So we went for it and we did it. And this is what the right STN lead looks like. The issue is, so she completely responded. So she, that day when she came in to turn the device on, she really couldn't walk unless she was really on a lot of medicine that was making her very dyskinetic, which is, I usually tell my patients to come in off of medicines when we activate the device for the first time, but she just couldn't do that. So then that day we turned it on and she didn't freeze again, and she's completely off of all her medicines. So the question is, what is this area that caused a response connected to compared to this area that did not cause a response? So we looked at that exactly. We looked at the functional connectivity of the volume of tissue activated on the left with the left volume, with the left STN lead, and with the right STN lead. And we did find in an N of 1 that this area looks like primary motor cortex, basically, was not activated on the left where she had no response, and it was activated on the right where she had a better response. So this is super preliminary and N of 1, so it's practically anecdotal. But we are gonna, obviously we're looking at many other factors that go into connectivity and at many other patients, and see if we see a pattern and see if we can study this prospectively moving forward. So I have a lot of hope for the future for DBS. I think that a path forward should really include those symptoms that really bother patients and that really affect their quality of life, not just improving the sort of the technology, but really addressing those symptoms. I think we need to understand a little bit better of what networks are activated in both cognition and motor issues and speech, and particularly gait, and characterize these networks and the nodes in each network and how they're affected, and then target the network itself, not just the anatomical target, and understand how different forms of modulation, right? Because it's not just deep brain stimulation. In the lab, we do transcranial magnetic stimulation. We do, some other collaborators here do vagal nerve stimulation, and really, direct current stimulation. So all sorts of stimulation that we can really learn and maybe target different nodes in the network with different more forms of stimulation, and combining them with rehabilitation approaches, both for walking and cognitive rehabilitation approaches with multiple, so really individualizing how we affect those networks. So that's it. This is kind of an old picture, and the team is bigger, so it's definitely not a complete picture, but Dr. Takic and Dr. Roland are neurosurgeons. Dr. Bartley is our neurophysiologist. Tracy Millman is our nurse coordinator. And then Travis is our neuropsychologist. And then this is Dr. Cooper and Dr. Rodriguez Porcel. We have we're a group of 6 going on 8 movement or shoulder neurologists that all participate in the program. And we have 2 new APPs that do the programming. They're currently training. So we have a nice group. This is really the folks that I work with a lot in the research side of things. So I definitely like to highlight Dr. Lynch, who's a postdoc in the lab, who did those representations in the last couple of slides. These are our coordinators in the lab. This is the brain stimulation lab coordinators that have really helped me a ton. These are my imaging coordinators in the Center for Biomedical Imaging. And then these are the folks in the gait lab. There's a whole center over here where we do a lot of gait research, and Steve Kaus has been an amazing mentor for many years. And then with Emory, so Dr. Factor and Dr. Wickman are my long-standing mentors since I was a fellow back there. And then Leo is a close collaborator that was here at MUSC with us for many, many years and is actually over at Emory now. So we miss him. But with that, I'll stop and leave time for questions.
Dr. Revuelta, thank you very much. Great talk. Actually, some of the very complicated things you presented in such a simplified way that actually I think many people really wanted to hear that. We have many questions for you. So I'm just going to start with them. Parkinson's disease is not a blanket diagnosis. Are there any markers, for example, or in particular, any genetic markers that would allow for better predictive outcome, which would help guide surgical decisions?
Oh yeah, that's a great question. Probably when I came out of training, probably 12 and a half years ago now, people would ask me all the time how many patients with Parkinson's have a genetic diagnosis or a genetic cause for the Parkinson's, and I'd say, oh, it's very little, maybe 5%. The number has grown, and people say 10, maybe 15%. And then I say, well, it doesn't matter. Like, so what? Like, if you have a gene, then what am I going to do with that? I'm not going to treat you any differently. So what's the point? But recently, we started to think about, there is a point, patients with GBA mutations, for example, don't seem to do as well with DBS. And so I don't think we know 100% by genotype, who does better and who does worse. But I started genotyping all of my DBS patients, and we have a genetic counselor that actually comes to our DBS conferences. And so everybody has, and we've, it's not like I'm denying DBS based on genotype or anything like that, but I want to look at this a little bit more closely, because I think it's important.
Acceptance of brain surgery for something like Parkinson's disease has been slow. How do we change physician and patient perception of surgery so that it is more embraced rather than a last resort, which is the typical situation?
That's another good question. I feel like, that's been certainly a struggle 10 years ago, for sure 20 years ago, but it's less. We have to, I think, get better. So, we go out there and we say, well, refer more patients, but then it's hard to get in to see us. And then when we do, then we might turn somebody down, and then the referring physician, doesn't like that. There's lots of, I think we need to build relationships with the community and do talks like this one so that we can, really explain to people, I'm a neurologist. I have no interest in doing unnecessary surgery on anybody. We're very cautious. And when we turn people down, it's just because we think that it's not something that's really going to particularly help them. But, we're happy to continue to see these patients. It's just every referring provider I found has a different motivation behind why they send a patient. Some patients are like, some doctors are like, this patient's too complicated. I just get them in for DBS because I know that they'll take them. And some people really want to see their patients back. And they're like, oh, if they do DBS, I'll never see them again. So it's just about understanding the expectations of the referring docs and building a good relationship and good communication, and then having enough room to see these patients, evaluate them, and do the surgery that you're supposed to be doing, which is not easy. Big team.
Why not in Parkinson's disease? Why not bilateral implant all patients up front?
Oh yeah, that's a big controversy. Well, at least in my world. So most people do, I would say. So I remember, so I trained at Emory where a lot of the early work in DBS was done, and before DBS it was lesions, right? So pallidotomies, thalamotomies, maybe even subthalamotomies. And if you did a bilateral lesion, patients did very poorly. So they developed like pseudobulbar palsy situation, dysarthritic dysphagia. They did very bad. And so they knew that, and they would never do bilateral lesions, and they will wait at least a year. And I think that's the mentality that when DBS came, they would do the same. So that's just what we did. We never really it was very rare to consider a bilateral simultaneous DBS. So then a few years ago, I went to a conference in Europe, and it was all a DBS conference, and there was an entire session on ataxia for patients with essential tremor. And I was like, that's weird. Why would you do that? I'd never get ataxia after DBS. And I realized, oh, it's because they do bilateral simultaneous. So we see a lot of, I see a lot of ataxia and worsening balance in Parkinson's disease with bilateral simultaneous surgeries. Even issues with cognition. It's a lot. I mean, it's a 2-hour surgery for one implant, and it's at least a 5-hour surgery for a bilateral implant. So it's a lot for my more fragile patients. So we're pushing the envelope both ways, right? So I've done several 90-plus-year-old patients with essential tremor. I've done several patients in their late 70s, or 80 with Parkinson's disease. And so to do a bilateral surgery in that population is tough. So the long answer to say you get more side effects in my experience with bilateral surgeries, and this is a more cautious approach.
Do you think freezing of gait will be helped more by adaptive technique or new targets?
That's a good one. So I don't know. I said some provocative stuff that, I'm just surprised that people are not really talking about using adaptive DBS for freezing a gait. I have no evidence. I've never seen a patient or even a claim that someone is doing a lot better with adaptive DBS for their freezing a gait. It's just a thought. New targets have not panned out. So, the new targets is particularly the pedunculopontine nucleus, a PPN DBS. And I haven't seen, so there was a lot of controversy, a lot of early work that patients were implanted, and without us really knowing what that area did. So we haven't really seen a lot of, it's been very mixed. So it seems like instead of new targets, maybe we should look at exactly what's happening with the current targets and understand what we're doing. That's what I think. But there's a lot of differences in opinion on that one.
Yeah. Have you used cycling on the Medtronic device to help with freezing of gait?
Yeah, no, I haven't. So I've heard of some folks that have used that before. I just haven't seen, even I talked to some of those folks, and they're like, it sometimes works and it sometimes doesn't. So I haven't been that convinced. I use cycling in research because we were doing more DBS combined with fMRI. So when I want to see what lights up kind of live in the brain, we do like a 30-second on, 30-second off in the scanner, and we can compare kind of like a block design for functional MRI, and we can see that, but not I don't use it therapeutically. Only Medtronic does the cycling though.
With less invasive pumps coming into the market, also the higher utilization of focused ultrasound, in addition to DBS, is your clinical practice changing on who gets referred for DBS?
Excellent question. The short answer is no. I didn't talk about focused ultrasound today. We don't do it. We might soon start doing it. The real short answer there is that focused ultrasound has a much higher rate of side effects. The side effects are permanent, while they are not permanent in DBS. Most of the side effects, if you have dysarthria or if you have dyskinesias, all these other things that we barely even talk about with DBS. We don't talk about them because they're reversible and adjustable. So you have a much higher rate of permanent side effects with focused ultrasound and a much lower rate of efficacy. And so I think the research is great. I think we're moving in the right direction. I think one day maybe we'll be doing a ton of it. But right now, if you come in to see me for DBS and you say, should I have DBS or focused ultrasound? I can't ethically recommend a therapy that has much higher incidence of side effects and much lower efficacy. So I don't recommend it at all.
And we have more questions, but I'm going to squeeze in one more, a quick one. In the patient you showed where you had contralateral stimulation and it improved freezing of gait, in the functional scanning when it lit up, was it a primary motor and supplementary motor cortex?
Yeah, I was hoping it would be more SMA because I've done a lot of research with the SMA, but it didn't seem to come over, so medial. So, I mean, and you don't know, these things just it's a map based on functional. This is on the normative connectome, so it's not even her own functional. It's just a map based on 1,000 brains with healthy controls and functional connectivity there. So, what areas are functionally connected in the big normative connectome? So, it looked like primary motor was involved. Would there some stuff more anterior, maybe prefrontal? It looked like a little bit, so we'll have to see. I have to stack on several more patients and see if that pattern holds. But it's pretty cool though.
Dr. Revuelta, thank you very much for getting all these great response about the lecture. The lecture was definitely very, very well taken. Thank you very much and have a good day.
Bye.
Yep.